Welcome to the Living Life Well show, the intersection of God's Word, today's science, and healthy living with common sense application, all based on the truth of the Word of God. I'm your host, Dr. John Skelton. Now let's get straight to the truth. All right, we're back for part 2 with Dr. Beard, our functional dentist and sleep medicine practitioner, who is going to really shed some light on the sleep cycles, the importance of making it all the way through an entire sleep cycle, and how trying some other sleep aids and different things can disrupt that action. As well as she'll talk about the differences between sleep apnea in men and women, and what you really need to look for when you do get a sleep study, and how best to treat it with all the options that are available. I think you'll really enjoy this episode, so here you go. Let's even go back to kind of the beginning. Let's talk about sleep and those sleep phases and what each phase really does and how that impacts, our health, and where in that cycle, because the sleep cycle is about 90 minutes or so, right? Depending upon the individual, maybe a little longer, maybe a little shorter. But can we talk about that and what we're doing in each phase? And if you will, just a little bit about, what potentially sleep aids do have on impact on our sleep.
Mhm. So I think I kind of said before, there's two main phases of sleep that sort of all the magic happens, right? And so the first phase of sleep is transitional phase. So that's the transition from being awake to being asleep. And then you have sort of that next step of sleep where you're getting rest. It's not deep sleep. It's sort of that, where you're asleep, but you're not like getting into that magic. There's some things that we could talk about, like case bundles and that kind of thing, but we don't really know what those do. So we know you're resting, but you're not getting into the good parts of your sleep. So your phase 2 sleep is about 50% or 50% of a sleep cycle. And so the phase after that is deep sleep. And that is the phase where, like I mentioned before, with kids, that's where growth happens. That's where brain development happens. That's where neurons make connections. I mean, it's super important developmentally. As a human gets older, they get less and less deep sleep. So it's super important for kids to have a ton of deep sleep early in life so that those things can happen. But the other thing that happens is hormone release, and not just, testosterone, estrogen, progesterone, but like thyroid hormone, all the different things that modulate all the processes in our bodies. That's where all of those things start to happen. And then just sort of the repair of all the damage that you did to your body that day, muscle repair, that kind of thing. So lots of really, really important things happen during deep sleep. And then after that, so right on the tail end of the sleep cycle was your REM phase. And I think that a lot of people think about REM being the most important phase. It's very important, but the things that happen with there is that they process our emotions, memory sort of gets solidified during REM sleep. When you asked about sleep aids, so sleep aids like Z drugs, so Ambien, Sonata, Lunesta, those guys, they get you straight to sleep, right? You skip over most of your REM. So you go from transition to phase 2 and you stay mostly in phase 2 your whole night. You usually do not dip into deep sleep when you've been medicated. So you don't get all that magic that happens during deep sleep, and then you skip right over REM sleep. And so you don't get any of that magic that happens during REM sleep either. And so you get rest. Your body is asleep. Your brain is not awake, but your body's not getting most of the benefit of sleep. The other thing about those drugs is that there's a huge rebound effect, right? And so you start to either wean yourself off or get off cold turkey. And then you have this big, insomnia rebound where it's even more difficult to fall asleep and stay asleep than it was before you started taking the meds, which is a real bummer when you've, had all these struggles sleeping. The other thing that happens is there's a REM rebound where REM will take up about half of your sleep cycle. And so you'll do all this wild dreaming, which can go kind of one or two ways, right? It can be slightly beneficial, but depending on what's actually happened, it can actually spur off into some anxiety, depression business that way. And alcohol is the other thing that really messes with your sleep phases. 1 in 10 adults uses alcohol to induce sleep almost every night. And so that's 10%, right? That's huge. So what's happening? So similar to the Z drugs, you don't get as much quality REM sleep. You don't get any deep sleep towards the beginning of the night, right? You're kind of in your drunk sleep, whether it's like 2 glasses of wine or a case of beer. You get sort of this garbage sleep initially. And then you sort of phase into your body tries to pick up the sleep cycle and it almost never happens. And so again, you don't get the good magic that happens in deep sleep and in REM when you try to alter your sleep cycles that way. And so it's unfortunately there's not a whole lot that we can do outside of really great sleep hygiene, obviously keeping your airway open while you're asleep and just prioritizing it, right? Like all the things that you do to make your night really good. Can't get away from this stuff.
Yeah. Yeah. Well, I worked nights for an entire year during the height of my emergency medicine career. And I did that because it gave me a regular schedule. But what I started having to do was take Ambien to go to sleep during the day. I just could not sleep. I'm extremely sensitive to light. And so I would take Ambien and I would find sometimes I just still didn't even go to sleep. I would be in that kind of very tired laying down, but it was like I was aware of everything that was still going on and just never really getting to sleep. And you're right. Once I came off of that, my sleep was even worse for several weeks before I was able to kind of get things turned back around. A lot of people deal with issues with sleep and they're looking for real benefit, but it starts with exactly what you said, really setting yourself up for success with that good routine, that sleep hygiene, having that real dark, cool environment, have a calming environment prior to going to bed, eliminating those screens, eliminating things that are going to wake you up at night. So making sure that you're giving yourself a couple of hours from the last time you ate or drank anything really before you go to bed so that you can get into that parasympathetic phase of our nervous system and really allow you to rest and digest and heal. And for a lot of people, gut health is really important. Well, gut health really starts with sleep.
Mhm.
If you aren't getting good sleep, your gut is not going to repair, healing from the insults that we put in our mouths every day to
Mhm.
go down our digestive system. Sleep is a big way to help with that. And so it's really important. So in talking about that kind of that compounding aspect of it, when we talk about obstructive sleep apnea, typically, the picture of that is 40, 50-year-old guy, overweight, and maybe has high blood pressure or diabetes and they just think sleep apnea goes with that. But what a lot of people don't realize is that the sleep apnea has probably been there long before those actually showed up in many cases and can be responsible for that. And traditionally in medicine, it's like, your primary care physician writes you for a sleep study. And then what do? You go, you either have it or do one of the at home tests now. And then it's a CPAP. I mean, there's really not much else. I know there's advertisements for the Inspire, and you can talk about that a little bit if you want. But specifically, I see more and more non-compliance with people that are on CPAP than I do with compliance and benefit. And when they even take their CPAP off, they're not noticing any difference. So I think there's a huge gap in there for treatment for sleep apnea because it is just so physiologically devastating to people. So can you talk a little bit about who really actually gets, sleep apnea now? Because it's much more than what I've just described with the typical person. And then talk a little bit about your approach with it, how you go about getting someone in to ultimately be diagnosed with sleep apnea and those things.
Sure. So you're right. You know, a CPAP is the gold standard for treatment of sleep apnea. The definition of compliance for a CPAP is horrible. It's like you wear it for 4 hours out of the night for 4 nights a week. And that's, I mean, that's not all you're sleeping. You know, you're still suffocating to death the rest of the time you're asleep. And so, and that's bare minimum, right? And most people, and really it is most after 3 months, it's 60% compliance. And after a year, it's less than 40% compliance. And so that, you know, and I guess if you've ever slept next to somebody with a CPAP on, you can know, you know why, right? Because there's cords and things, and it's just cumbersome. If you need it, you need it. But there's some other sort of treatment avenues that we can explore before we get there. The most important thing is finding it, or just like any disease, right? If you find it early and you can treat it more conservatively. And so again, as a dentist, so fast forward to adulthood, right? And we're looking in your mouth and we see maybe that you've been grinding your teeth or that you complain of jaw pain or migraine headaches, that kind of thing. So that's what it looks like early on. And that's called upper airway resistance syndrome, where at night you're asleep, maybe you got to sleep great, and you go from breathing through a water hose, and then your airway starts to relax and sort of close down. And then you go from breathing through that big water hose to a coffee straw. And so you can imagine if I made you breathe through a coffee straw right now, pinched your nose and put a coffee straw in your mouth and said, breathe, your body would freak out, right?
Yeah.
You would get a surge of epinephrine, your heart rate would go up, your body thinks you're dying because it could. And you wake up. So at night, when your body goes from breathing through a water hose to a coffee straw, you have that same panic attack. Sometimes you sort of stay asleep and sometimes you don't. It's sometimes you wake up and you're like, I guess I was having a bad dream. And then it's hard to go back to sleep, or then you kind of struggle and maybe you get up and do something and then go back to sleep, and then you don't get your sort of continuous 7 to 8 hours of sleep. Or upper airway resistance, that's sort of the pre-apnea, condition. And it's my goal for none of my patients to get to the apnea condition, because that's where you really are obstructing you stop breathing altogether and your body gets conditioned to that. And so you do have the surge of epinephrine, but your body responds to it a lot later. You've been not breathing for several seconds and your blood oxygen level drops. You're in emergency medicine. You know how scary that is when blood oxygen level drops. And then finally, when you get enough CO2 in there, you finally gasp open, and so that's that big snoring, those big, no sound and then big sound. And that's that patient, opening up that airway finally. And so that's super dangerous. But the thing right before that is just as insidious. It's just as dangerous because you are living in fight or flight all night long. And so you're in catecholamine, epinephrine, norepinephrine all night long, which is the opposite part of your autonomic nervous system that you need to be in. You need to be in your parasympathetic, so your rest and digest, where your hormones are being released, your healing is happening, muscle breakdown and build back up is happening. All of the sort of homeostatic, processes are going on during that deep sleep where you're in your parasympathetic nervous system. But when you go to breathing through a coffee straw, that's all out the window and you're just trying to survive. And so then you're in, you're super stressful sleeping.
So when that sympathetic nervous system is on overdrive, those cortisol levels shoot up. When you're doing this night after night after night, you're going to develop insulin resistance. You're going to develop high blood pressure. Your cardiovascular system is having to work on overdrive now because it's increasing in heart rate ridiculously because of those surges in epinephrine, norepinephrine, and cortisol even. Now you wake up in the morning, and this is a telltale sign that it could be sleep apnea too, especially if you're already a diabetic. is that you go to bed, your blood sugar's one level, you wake up in the morning and it's higher. That can indicate that you possibly have some sleep apnea. Not definitively, but it's a good indicator for that. And so that metabolic syndrome, that high blood pressure, high cholesterol, high blood sugars all go along with the sleep apnea because it creates such a disruption in how God designed us to, function. Just like you said, that parasympathetic is what's supposed to be taking over, but we're thinking a lion or bears chasing us
Mhm.
in the middle of the night. And so unfortunately, when you don't get sleep and that sympathetic is really revved up, that's what you feel like all the next day. And so, you mentioned, the CPAP and we kind of talked about, the 40 to 50-year-old guy whose
Mhm.
wife is saying, "Hey, you're snoring," you know, but it really affects a lot more people than just that obese middle-aged man. So
Mhm.
can you talk a little bit about that and how it might present a little bit differently and in other populations?
Sure. Just like cardiovascular disease and diabetes, it looks completely different in men and women. And so we kind of talk about having two adult types of upper airway problems when it comes to sleep. One is the old fat man, and one is the young fit female. And so men can be in the young fit female category, if and women can be in the old fat man category. And I know that doesn't sound very nice, but it's just kind of, we think about apnea as the old fat man, right?
Sure.
The big thick neck, like you say, the big belly, older gentlemen, maybe they smoke, maybe they drink alcohol, that all makes it worse, right? But the young fit female part of the population is huge, and it's not regularly detected right now. So I feel like that's a very underdiagnosed area. And so part of it is, and I'll just talk about the women, it looks different in women. Our symptoms, our complaints are different. A man will say, I fall asleep during in the middle of the day, or I fall asleep driving, or in, some inopportune time. We'll have him fill out these questionnaires, stopping, or questionnaire about how sleepy they are, right? Women don't get sleepy. We get tired. And you talk about chronic fatigue. Well, yeah, you're tired because you're not resting. The other way that's interesting to me that it presents in women, a symptom, is anxiety and depression. And so many women, this age of like 30 to 50, so it's kind of a big range, but they think they're anxious and depressed. The other way that we present is with tension headaches, migraine headaches, and neck and jaw pain. And so that's kind of why dentists got involved, because we were looking for ways to treat TMJ disorder. TMJ, when I was starting out, 20 years ago, that was a big deal. And it was sort of this like enigma of like, oh my gosh, I don't know how to treat that. Well, as sleep and airway disorders came and all this really great research has been coming out, well, it's a huge piece of the puzzle, that we can solve some of this pain that people are having in their jaws. But then it kind of it explodes from there, right? Then it's like headaches and neck pain and all kinds of stuff. And so that's kind of how it presents in this young fit female category. In the dental world, they're also usually grinding their teeth, chipping these front teeth. But then we look inside their mouths and they've got these tiny jaws. And so they didn't develop when they were kiddos, appropriately. So they've got these little bitty faces and little narrow noses that are beautiful, but they can't breathe, And so, and what they complain about, we'll say, well, how are you sleeping? Oh, well, I get up at 4:30 and I work out. And then you're kind of tired, but wired all day long, right? So you're like running on fumes because again, we don't get sleepy. We're just tired. And so anyway, so it looks totally different. The way it looks different with a sleep test is generally these patients don't usually obstruct very much at all. And so and that's sort of, I think, a missing link in the sleep test a lot of times, where we're only measuring when people completely obstruct.
Right.
And what really, I think there's some other modalities that you can look at where when they start to slow down breathing, or when things start to get relaxed and airway starts to close, and then it starts to get stressful breathing. So you've got this sort of inspiratory flow limitation, which is a really fancy way to say stressful breathing. So that's that coffee straw breathing. And so that looks on your sleep test like a spike in your heart rate. Okay, because it's scary, right? And that's the epinephrine going in. And then if your O2 dropped even 1 or 2 points, then it comes back up pretty good, because then you wake up, turn over, take a deep breath, and maybe even all the way wake up. What that does to you and how that's so hard on you physically is that if you were getting so relaxed to be able to get into that deep phase of sleep, so that's like there's two phases that are sort of the money spot with sleep, and it's deep sleep and REM sleep. And so if you were getting into that deep phase of sleep and your airway starts to close up and you freaked out, and your body, what it does is it goes from that deep phase and it launches you straight out of it. So you don't get the benefit of the deep sleep. So in adults, the deep sleep is hormones, repair. It's all of the muscle regenerate. It's all of the things that make us feel good, right? If it happens during the REM sleep, REM is when you process emotions, you process memories, you sort of categorize. It's like your mental categorization time, right? And so you put emotions and thoughts in boxes. And
Mhm.
so if this happens during REM sleep and you're unable to fully process the day, the weeks, the year, your life, right? Then you wake up and you're anxious because you didn't, or you're depressed, or all of those things are super linked. And so what's interesting is that if you are anxious and depressed during the day and you try to sleep, your REM is reduced, just because of those daytime symptoms. And so it's sort of like this cycle that you're kind of on, and then you get on sleep meds or depression meds and stuff, and that just makes it, that throws a whole nother kink in the in the chain there.
Yeah. Yeah. It's just a never ending hamster wheel,
Right.
basically. And you've got to break the cycle, and it's hard work to break the cycle many times. One of the things I see a lot with my clients in my functional medicine practice is, perimenopause. We see shifts, in hormones quite a bit. I kind of talked about earlier, and I alluded to this, but is it chicken or egg? Is it that you got diabetes and you're obese and that's what's causing the sleep apnea? Or was it sleep apnea was there first and that's kind of contributing there? Is there any really good link that we know of yet between early kind of perimenopause, say maybe that lady that's like 35 or so, and sleep apnea, or be able to really clue into any processes that may be going on there?
Yeah, sure. So progesterone is a really, really powerful airway supportive hormone, and the exact mechanism is not really known, but it sort of lends to it sort of keeps the muscles taut in your throat and in your airway. Estrogen and progesterone are really powerful in the genioglossus contraction, so that your genioglossus is basically your tongue muscle. And so that's you talked about Inspire earlier. That's the muscle that the electrode is implanted in to protrude or stick out your tongue to get your tongue down to your airway. And so progesterone and estrogen are really powerful mediators of that. There's also a lot of information coming out now where when women, postmenopausal women or perimenopausal, that have sort of bottomed out on their hormones, have hormone replacement therapy, whether just progesterone or progesterone, estrogen, their sleep scores get way better. And they were in a super apneic. When a woman goes through, this sounds terrible, but when a woman goes through menopause and it's at the other end and there's no hormones on board, she goes from that young fit female, so having a competent hormone spectrum, that is holding things, hormones hold everything up, right?
Right.
So,
Yeah, absolutely.
but this is one of the things, and when that goes away, they sort of transition into the old fat nearing category, and then they really do, their sleep studies look like a male pattern sleep study where they obstruct a bunch, they make big noises, that kind of thing. And so hormones are pivotal in sleep and sleep health for sure.
Yeah, yeah, absolutely. And so that's one of the things I ask every time when I get a new client is,
Mhm,
what's your kind of sleep hygiene to an extent? And, how often are you waking at night and why?
mhm.
Are you waking to the alarm every day, or are you waking and feeling rested and you're naturally waking up? Because sleep is such an important aspect to every single area of our life. And so, as far as testing goes, you mentioned that, women with this, you know, traditionally what we've looked at is kind of the man that actually, goes out next, stops breathing.
Mhm.
But you mentioned how we can see these differences in men and women both that aren't maybe quite to where they're getting to that true apneic spells. And is that something that, your general doctor that's, ordering a sleep study for you and is maybe being read by somebody else, but is that something that is more common knowledge that people are really looking at, or is that more something that people that like you that are intimately connected with this field are really the only pioneers that are kind of seeing?
Sure. I I don't know the answer to that. I hope that people are learning about sort of what comes before. It's like pre-diabetes and diabetes. This
Yeah.
is like pre-apnea and apnea. And you want in pre-diabetes, there's still an action to be done. There's things to do, not just wait until it turns into diabetes. And so what I counsel my patients when I refer them out for their sleep test is to tell them that we suspect that because there's no snoring and because there's no, sort of those typical male pattern apnea things that are going on, but we suspect upper airway resistance. And so that keys that sleep physician to, know some of the history, right? And to know to look for the smaller drops in O2 sat with the big changes in heart rate. And so those two variables alone can really kind of pick at it. Then also the patient's history, their sleep history and what they're telling you about what they feel and that kind of thing. I think that the men and women sort of in that upper airway resistance syndrome category are, if not treated, are setting themselves up no matter how well they take care of themselves, are setting themselves up for a problem down the road. I'm patient zero in my office, right? Like my husband and I got into all of this because my husband, who I love dearly, I could not sleep next to him because he is a snorer from like day one. He's tall, skinny dude, but snores. And so I was like, okay, I'm gonna fix you. And then in all of my research and studies and all the things that I've done, I'm also as bad of a patient as he is because I do the things where my heart races at night, and not treated. My heart races at night, all of those things. And I was having a very difficult time managing stress, managing cortisol levels. I wasn't really a headache person, but the getting up at 4:30 in the morning to work out and like, trying to do what's right for me. And so, but I was still setting myself up for damage down the road. So I think that if these patients I'm trying to counsel these patients to tell their sleep doctor, whoever is going to run the sleep test, whether it's a home test or a lab test, just say, this is what I'm worried about. So can you comment on that? And unfortunately, there's not so much of medicine is, well, what's insurance going to pay for? You know, and insurance, they won't pay for anything unless it's all the way to where your AHI, your sleep score is a 5 or above, and then they might pay for something. And that's already disease. I mean, that's already really pretty bad. And so if we could, like all the preventative medicine that we try to do, if we could catch it before it gets anywhere close to an AHI of 5, then we win. And we've bought ourselves health and probably some longevity and, all the good things that we're working towards.
Not only, that, but I mean, your health span is going to be much
Mhm.
better.
Oh,
not just years, but your healthy years,
right.
in that when you can get in that early stage and nip it in the bud. And so, I like the idea of the home sleep
Mhm.
studies and those things being more in your natural environment and those things. Are they as accurate? Is it a good study to get, or do you always recommend, kind of the sleep lab study for them?
I think of a home sleep test sort of like a CBC and Chem 7, right? Like your bare minimum blood work, right?
Mhm.
And if something pops up in a sleep test, in a home sleep test, if it can be pretty, they get a lot of information from a home sleep test. But if something funny comes up, right? Like maybe they think that there's some central apnea going on instead of just obstructive sleep apnea, then I think that a lab test is warranted. I think that probably the majority of patients could start out with a home sleep test to save the money. That's like a $300 thing versus a $6,000 lab test, or more. I don't know. And I'm not saying that the lab tests don't have a spot or an importance, but I think just to get more people tested and treated, I think a home sleep test is probably a great option.
Yeah. So take away CPAP, take away diet and lifestyle modifications, losing weight, those kinds of things, mitigating your, food and drink intake prior to bed that's automatically going to mess with sleep. We've cleaned up, sleep hygiene as much as possible. What kind of things are you able to offer, your patients that come in to see you? And what is the, I guess, success rate and also how often do they actually stick with those treatments in comparison to like the CPAP?
Sure. So dental sleep medicine is primarily we make appliances, right? We'll make what's called a mandibular advancement device, which basically holds your lower jaw down and forward. And everybody's a little bit different, to what degree they need that to happen in order to support an open airway. So what that does is that uses your mandible or your lower jaw as a tent, the hard tissue to support and to sort of tent that airway open. So even when you're relaxed and on your back and, all the worst snoring situations and apneic situations, that airway is held open because your jaw is forward. And so we make a whole catalog of those types of devices depending on the patient's, dental situation and need and all of that. The benefit of them sort of what they have over a CPAP is the compliance is quite a bit greater. It's so much easier to travel with, it's easier to tolerate. There is sort of a, a titration period where we have to sort of slowly crank your jaw forward over several weeks before it's effective, but they can be pretty darn effective. We can pretty regularly, predictably treat sort of mild for sure, and mid moderate to kind of that. So AHI of 15 to 30 is moderate, and if it's about 20, 23, we can pretty predictably treat all the way to no apnea. If it's over that, we can get we can pretty predictably get a patient to mild apnea. And so, the severity of your AHI or your apnea score is directly correlated to the symptoms and sort of the downfall of what happens from the severity of your disease to the severity of your cardiovascular disease or your, diabetes or whatever metabolic thing pokes through. But the other thing that these devices can do is if the patient is severe, a thing that we do pretty regularly is we work with the respiratory therapist and the sleep docs to do therapy. So we can use a device and tent that airway open, and then the CPAP doesn't have to blow so hard.
Yeah.
And so it makes the CPAP a whole lot more tolerable for the patient. And then if it's more tolerable, then they're more likely to put it on, you know. And
Yeah.
if they take the CPAP off in the middle of the night for whatever reason, they still have their device in. And so they're not severe. The rest of the night, they're like high mild, probably, you know. And so there's lots of different ways that the mandibular advancement devices can fit into the treatment of apnea. The other way in the dental world that we can sort of augment this disease pattern is there's some structural stuff that we can do, right? So even adults can have their palate expanded. We can do, and it's a kind of a big surgery, but we can make jaws wider, more forward, more prominent, even your lower jaw, to make your airway bigger, to make your tongue fit in your mouth so it's not back in your airway. And that's sort of obviously case dependent, but that's definitely an option. There's lots of orthodontic processes that they can do to really help the the airway support that goes on. I really think that an airway minded orthodontist is a really, really powerful tool in your toolbox. The other thing is if a patient's got a tied tongue, that's a lot of times, if they can't get their tongue up and through their palate, over their palate, like that's the appropriate position and posture for your tongue, resting posture for your tongue. If you're tied, you can't get there and your tongue is down and back in an awake situation. And so you're really having to compensate all kinds of positions while you're doing that. And so it, there's several different things that we can do to help, but we sort of our main gag is, in the most, the easiest thing to get started with is obviously the mandibular advancement device.
Okay.
Yeah.
So if somebody comes to you and says, my wife or my spouse is telling me that, they really think that I have, sleep apnea. I'm snoring a lot. They're telling me that I'm stopping breathing and those things. Now, obviously, that's a situation without a sleep study. Probably insurance wouldn't pay for anything
Mhm.
without a sleep study. But what can people do if they do have that kind of a situation? Could they still come see you at that point and you be able to help them, or they absolutely, need a sleep study first before they could be adequately treated with these oral appliances?
So in my world, I'm not going to treat um, a suspected apnea patient for apnea without a test. I my biggest fear is that I would sort of take care of this one symptom, but there's a bigger problem brewing underneath it. And so I think that it's really important to be tested. And that's why I have even my people that don't snore, if they complain about their sleep, I just say, gosh, sleep tests are like blood tests. Like, you don't know what's happening until you get it tested, So it's you should do that routinely, just like your blood work. So
Yeah.
I think that there's a lot of things similar to things in medicine where you can treat the symptom, you can treat you know, the diabetes with just diabetic medicine and not what's going on really. You can treat depression with antidepressant, but what are you really doing for the patient? Like there's probably something else going on that's causing all of that. It's just the same, you know.
Yeah. Well, and quite frankly, most disease states are multifactorial. Usually, many things are going on. And so you have to address all the things. But I know for convenience, and this is true in my practice too, I'll have, clients come to me and they just want me to go ahead and treat based on symptoms, based on, whatever other factors may be going on. And you can try and do that, but you're always going to get very limited results. You're going to miss things. And so really moving forward with getting that sleep test is going to be really, really important. So
Right.
I really appreciate you coming on today. I think this has been excellent. I think we've all learned a lot today. And so if somebody is in the Lubbock area, what is the best way if they want to seek you out for themselves? What's the best way for them to get a hold of you and start that process?
there's sort of two sides of the practice, right? So Renew Dental is my dental practice. Our website is renewdentallbk.com.
Okay.
The other side is Renew Sleep, and that website is renewsleeplbk.com. And they both have links back and forth. I mean, it's all me. Our office phone number is 806-793-5454, and that will reach both offices there.
Okay.
Yeah.
Well, great. Well, again, Dr. Beard, I really appreciate
Oh,
you
gosh.
coming on, and I think this is going to be really great for a lot of people.
Thank you so much for having me, and thank you for the investigations that you do for your patients, because that's everything. I think that you guys that are pioneering the functional medicine community, I mean, it's a big deal, and if we can help people get better from the things that are actually wrong, I think that that's the way to go. That's get them back to where God wants them, right? We
Yeah,
messed it up, so let's get them back to where the way He made us.
absolutely. Absolutely.
Mhm.
Absolutely. One of the resources that you can employ to help you know if you may need a sleep test is going to restassuredonline.com. This is Dr. Beard's trusted resource for getting your at home sleep studies. They also have an assessment to help you really determine if you or your loved one may need to proceed with a sleep test. So, I hope this has been beneficial. I hope this has been enjoyable. Thanks and God bless. That's it for this episode of the Living Life Well show. If you like what you've heard and want to learn more, or want to know how to put this into practice for yourself, go to livelifewellclinic.com. Until next time, this is Dr. John Skelton saying go out and live the truth so you can live life well. The preceding is for entertainment and educational purposes only. It is not meant to be used to prevent, diagnose, treat, or cure any condition. The information contained in this show does not substitute the need for a qualified medical professional, nor is it meant to provide medical advice or services. If you feel information presented in this show may apply to you, we recommend you seek out the help of a qualified medical professional who can evaluate and treat your specific concerns.